Sure.
amount of medications they're on or insulin dependent.
Right. I would say the literature I've seen involves the duration of diabetes. Very few of these case control studies have data like an A1C or something like that, and we don't, unfortunately. There is an interesting association with diabetes duration, which I'll get into in the second WIP when I talk about metformin duration, because there's an interesting interrelation there. I will say that it's complicated by the fact that diabetes is both a risk factor for pancreatic cancer as well as a consequence of pancreatic cancer, right? As the pancreas is being sort of consumed by this tumor, eating beta cells, you actually get a hyperglycemic state there. And so there's some thought that diabetes diagnosed just before someone's diagnosed with pancreatic cancer actually is reverse causality, right? That's just undiagnosed pancreatic cancer, and that could be the presenting complaint. So there actually seems to be like a peak in risk in these observational studies, right, in like a short-term diabetic, but that's thought to be due to reverse causality. So it's a complicated analysis, and we'll talk about it a lot more in the next WIP. Anyway, back to where we were. We got this result. Within diabetics, metformin doesn't seem to change your risk of pancreatic cancer. But then we wanted to see whether confounding by indication was actually present. So we can expand this analysis with the same exact model out to our population of 1,400 people and see if that drastically changes our point estimate. And so we did that, and we get this. So confounding by indication is present. And if we hadn't realized it, we would have said, oh, metformin gives us this increased risk, statistically significant, 87%. But that's really just by the fact that these people have diabetes, not that they're taking metformin. So that's what we can show here. So basically in summary, this was, and I should say, so this was a single variable of a single drug. This year I'm looking at several different variables for several different drugs. And you can imagine doing this many times. So in summary, pancreatic cancer is currently caught very late and has a poor prognosis. And we need to do a better job of understanding both risk factors and protective factors for the disease. Whenever we're looking at a medication effect, we need to consider at least confounding by indication. In this case, since we're looking at diabetes, it is present for pancreatic cancer. Propensity scores can be used in observational studies to actually increase inference by creating that quasi-randomized state, as well as increase your statistical power by taking a multivariate model and bundling a lot of variables that you don't want to independently analyze. And finally, from this result, there's a null effect of metformin use in diabetics as far as influencing pancreatic cancer risk. So future directions, which your guys' questions, very apt, have sort of led to the next WIP. We'll talk a lot more about metformin duration of use, and whether there's a dose response, and also how that relates to diabetes duration of use. Because that brings up another idea of confounding by indication, right? If, say, like metformin, you see a dose response and the risk drops as you take more metformin, the risk of diabetics also drops as you have a longer duration of diabetes potentially due to that reverse causality argument. So there's more stats to be done there. There's the relationship of, well, this is sort of what I'm getting at, the relationship of metformin and diabetes duration. And we'll move on to statins and NSAIDs and aspirin. Those analyses may be somewhat less complicated because like high cholesterol, for example, doesn't have the direct mechanistic link to pancreatic cancer that diabetes does. So potentially confounding by indication will be less of a factor there. And NSAIDs and aspirin are nice in that they are prescribed for a variety of different diseases, so we will likely have people with and without the disease that took NSAIDs for different diseases, and you may be able to model certain disease states out in that situation. So I'd just like to take a moment to thank Dr. Koh, who's sitting in the back, one of my mentors. Dr. Bracci, who's a biostatistician that I'm working with over at Long Heights, couldn't be here today. Yeah, she is really cool. And then the CTR pathway, Dr. Kolevsky, Dr. Chinong, Kim, it's great, and Amina at Raptor, very helpful. So, thanks for listening.
Yeah,
yes.
Can I add another thing for you? Possibly do this year. I mean, I think with the other evidence and the conflicting evidence, have you thought about doing a systematic review?
Yeah, and there have been some done. It's interesting, when you look at the forest plots and the weight, so much of the weight is given to these case control studies because, all the others have so few pancreatic cancer. And the one randomized control study that's been done, had 20 cases in hundreds of thousands of patient years. And so those are being done. Maybe I'll be the next one to do one. But so far I've sort of been,
I
been
mean,
pretty
by adding your data to
Sure.
them, because they wouldn't have your data.
Exactly, and I
There's
mean,
a
yeah.
systematic review class you can do.
Oh, is that right? Oh,
During
okay.
the year.
That's news. That's good. At very least, I'd like this data to be in the next meta-analysis, whoever does it, because I think it's, though it is null, I think it's still informative.
No, it's definitely full.
All right, thanks, guys.
Just
Oh, yes,
just
please.
A couple of things. So this data set we have, I mean, we actually also collected DNA on every, well, we collected either blood or buccal swab samples for DNA on individuals. So in addition to these sort of risk factors, I mean, we're going to be able to really probe the sort of the particular candidate genes or polymorphisms that we think may modulate the risk, whether it be from diabetes or even at a risk of the gene, the offending agent, and the development of cancer. So that's going to add an additional level of complexity. But this was originally intended also as a molecular epi study beyond what you're saying. The other thing I want to mention is that, you know, what Evan is talking about is the risk of development of cancer as modulated by, say, metformin or statins or stuff. But there's also a lot dealing with the survival rate of individuals once they have cancer relative to these medications, or to, you know, the classic example of that is vitamin D, right? May be protective for developing cancer, may actually also affect the survival of individuals once they have cancer. We were all talking before, well, you can't see, you know, metformin right now. You know, metformin it's only diabetics who are taking it. Well, now a lot of folks, even absent diabetes, who have a cancer diagnosis, are being started on metformin under the possibility that even after the development of cancer, it may somehow modulate cancer progression and enhance survival. Now that data is really even a lot more limited than that, but just pointing out that, you know, we may see drugs like metformin or statins or things like that be used not just as potential preventive agents, but even as treatment once folks are once they have cancer, you're trying to use any adjuncts possible to improve their outcomes. So that's a whole separate thing. Unfortunately, we don't have this the survival data captured for this case control study to be able to look at those things, but that would be, you know, that's a whole additional level of research.
Thanks. Thanks, guys.